Acute coronary syndrome, an absolute medical emergency. This presentation is definitions, introduction, approach, and an overview of the presentation and pathophysiology. It'll discuss the basic concepts of management, so we're going to touch on that while trying to elucidate what acute coronary syndrome really is. If you're here, it means you're interested in internal medicine, hopefully an aspiring cardiologist, and you need to activate your critical thinking, especially when approaching this kind of emergency, and kind of remain or kind of maintain those skills to approach other medical emergencies. Let's see if we can make that happen by discussing while challenging some of your inherent understandings of acute coronary syndrome, one of the most critical emergencies that you are going to find in absolutely all fields, because life is at stake. Sometimes my answer to a frank question in this presentation that I'll postulate to you will be in the form of another question before giving you the info that you need, or in the form of a case, and that's going to hopefully get you in the mindset of what it is that I have to do. And so, without further ado, acute coronary syndrome is a spectrum. If you're a medical student and hearing about these terms for the first time, this is going to be really exciting. Acute coronary syndrome is the term that denotes any of a range of presentations associated with sudden reduced blood flow to the heart, known as ischemia. And myocardial infarction is one of those presentations. MI is the denotion that we use for myocardial infarction, and it basically is what is commonly known as heart attack. So now you can tell that this spectrum, the arrangement or the different kinds of acute coronary syndrome, the most common ones in the spectrum are unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. And so we do focus a little bit on the ST part of the ECG, and that means that the definition here is strictly an electrocardiographic definition, if you're being very strict. But this presentation is going to show you that the definitions are important and that we actually consider the clinical aspect more so as science and the history of acute coronary syndrome went on. So the outline of this presentation, we're going to have definitions: myocardial infarction versus myocardial injury, myocardial ischemia versus myocardial infarction, for example. And the idea of ischemic heart disease as an encompassing umbrella of these presentations, whether acute or chronic. And then acute coronary syndrome needs to be discussed as the spectrum it is. And it is actually one of the most wonderful terms we have because it alleviates the need to stick to a specific definition and is going to basically alert you that no matter what the exact pathophysiology or the exact diagnosis is, this patient is in acute coronary syndrome and therefore needs to have the emergent kind of approach. And we're going to try to answer what are the coronaries and what happens and why, and what are the risk factors, and understand why you must treat early. And that is really to prevent irreversible damage and to improve the function of the patient in the future. We're going to discuss approach to the most serious of all emergencies, which is acute coronary syndrome, and we're going to have the basics of that outlined. And of course, part of the approach is going to be the medical management and the follow-up, the long-term plan, and so on. So there is an added benefit to this presentation. While we're going to be discussing those outlines, I want you to know the normal coronaries and the normal presentation of ECGs. So we're just going to kind of like touch on ECGs a little bit. I'll show you a few pictures. Don't be intimidated by them. And you're going to, because only when your eyes see something abnormal, you can localize the anatomy. And if you don't know what normal is and you don't have a feeling that something looks abnormal, then you're not going to pick on it. And that also means that you should also get an idea of which leads correlate to anterior, lateral, posterior, inferior areas, and to which coronary. And that will take you a long way, really, in the treatment. And while you're going to have to study ECG in details, this is going to kind of give you the feeling of empowerment while approaching those otherwise intimidating topics. So myocardial infarction versus myocardial injury. Let's look at this. No coronary disease in this patient. So this is a patient who did an angiogram and had typical chest pain, but turned out to have normal coronaries. But the patient had the lab tests that prove there was a myocardial injury. The patient had the ECG changes that prove that the patient have a myocardial injury. And so with time, we started to kind of differentiate between myocardial injury and myocardial infarction, where people used to jump on the horse of myocardial infarction every time there was ECG changes and or enzymes being the most important biomarkers, mainly in the form of troponins and CK and B. We're going to touch on that. And so injury versus microvascular disease are the possible differentials when you do an angio and find that the epicardiac coronaries are normal, because the coronaries, as you see in this beautiful picture, keep branching on, and that means that you can have a microcoronary disease but still not have localized disease on an angio, because the angio is not going to branch to all the small branches. And so it's not going to show it. You're not going to see all the branches of all the coronaries at the smallest level. And so we have an entity known as microvascular disease. And then there's something called MINOCA, which I'm also going to touch on in this presentation. So this is going to be a presentation that will also put labels on many things that might otherwise make you feel that you are disengaged in a morning meeting, or not understand what's going on when a resident or a fellow or even a consultant is discussing a case. We're going to touch on all the common things that are related to myocardial infarction or myocardial injury. And so microvascular disease is one. What about, why did I then just say, okay, injury per se? Because, well, you can have an infection or an inflammation or a contusion without an actual coronary disease that's going to present itself in the form of an injury. Okay, here is a term, myocardial injury. So in 2018, once again, a group of experts gathered, and they are the task force on the definition of myocardial infarction, and they come from all the different associations, the American Heart, the American College of Cardiology, European Society of Cardiology, and they put the fourth definition of myocardial infarction, and they said, okay, the term myocardial injury should be used when there is evidence of elevated cardiac troponins, which is our most specific enzyme for myocardial infarction, with at least one value above the 99th percentile upper reference limit. The myocardial injury is considered acute if there is a rise and or fall in the troponin value. Now, add the myocardial injury to at least one or more of the following, and you get yourself a myocardial infarction. Notice here that we said type 1, 2, or 3. So you should automatically know that there are multiple types of myocardial infarction. Okay? Before going on linguistically, infarction alludes to the death of tissue. Okay? From a strict pathologic definition. Again, the term acute myocardial infarction should be used when there is acute myocardial injury with the clinical evidence of myocardial ischemia, with the detection rise of the same thing mentioned before, more than one value above the 99th percentile upper reference limit, with at least one of the following. So one or more of the following. So those are, so in addition to myocardial injury, you get symptoms of myocardial ischemia, say typical pressure, central, retrosternal chest pain, new ischemic ECG changes. So say, for example, an ST elevation somewhere, a development of pathologic Q wave. So that is the normal progression of an ECG. It's been some time. Now there's poor R wave progressions or Q waves. That means this is an older MI. And a Q wave literally means a Q wave. There's no R. The first deflection in the QRS complex is a Q wave. And that is an indication when it's localized somewhere that is consistent with a coronary, That means it's an old MI, most likely. Or imaging evidence of new loss or valuable myocardium or new regional wall motion. So this could be a nuclear imaging. This could be an echo, for example. And that would be consistent with ischemic etiology. Or identification of a coronary thrombus by angiography or autopsy. Of course, not in type 2 or 3, because those are not the ones included here. And we're going to touch on that real quick. Okay, so let me tell you a story. And this is an excerpt from the paper published on the definition of myocardial infarction from the task force mentioned before. In the 19th century, post-mortem examinations demonstrated a possible relationship between thrombotic occlusion of a coronary artery and myocardial infarction. However, it was not until the beginning of the 20th century that the first clinical descriptions appeared describing a connection between the formation of a thrombus in a coronary artery and its associated clinical features. Despite these landmark observations, considerable time elapsed before general clinical acceptance of this entity was achieved, in part due to one autopsy study that showed no thrombi in the coronary arteries of 31% of deceased patients with an MI. Now, remember, I kind of like played the devil's advocate and put an angio there with a patient who had typical symptoms but turned out to not have an obstruction. Of course, you can have a microcoronary disease that's not going to be seen because they can't even dissect the smallest of the vessels. And of course, you can have a thrombus that may have embolized or even resolved, and of course, you can have a non-thrombotic occlusion. But then you should also think to yourself, if myocardial infarction, that is actual injury that already occurred because of ischemia or death to the muscle, occurred because of an obstruction, that is limitation of perfusion, but maybe the limitation of perfusion is not necessarily related to obstruction, right? Keep that in mind. Let's continue on. The clinical entity was then referred to as coronary thrombosis. Although the use of the term MI ultimately prevailed, because it kind of made sense, over the years, several different definitions of myocardial infarction appeared. And that led to controversy and confusion. Hence, a general worldwide definition for MI was needed. This occurred for the first time in the 1950s to the 1970s, when a working group from the WHO, the World Health Organization, established primarily electrophysiologic definition based on electrocardiographic based, that's an ECG based definition of MI, intended for epidemiologic use. And that's kind of how we ended up using ST elevation, non-ST elevation as a primary differentiator, but we accepted to keep that because we found that there is a clinical significance to the severity of the perfusion defect. That's why we kept especially the ST elevation MI. That's important to know. So when they had those older definition, there was the Q-wave MI terminology used, and we discovered over time that Q waiting for the ECG to Q out, that means the MI has already been old. And so they put the following clinical criteria for MI. The clinical definition of MI denotes the presence of acute myocardial injury detected by abnormal cardiac biomarkers in the setting of evidence of acute myocardial ischemia. Okay. Remember how a historic series showed a bunch of patients having died of MI presentation or MI-like presentation but found no thrombus, and they thought that the entity was purely MI thrombosis, and how the task force on the definition told you there is more to it than just myocardial infarction. There's an entity called myocardial injury, and injury is not necessarily infarction, so you might not necessarily want to take the patient to a cath lab, for example, and open their vessels. There are other differentials of acute coronary syndrome. Takotsubo, for example, is a broken heart syndrome due to a catecholinergic surge in the apex of the heart, which is the part of the muscle that is most innervated with sympathetic nerves. All of it is, but the apex is more so. So when there's severe emotional stress, like someone losing their beloved one, for example, suddenly in an unexpected manner, and they get very stressed, they can have this infarct-like pattern. in the apex of the heart and actually present in the same way as acute coronary syndrome. MINOCA is the myocardial infarction with non-obstructive coronary arteries. This is the entity that was denoted that tells you, okay, this patient has all the features, electrocardiographic and biomarkers and clinical, all three hallmarks. Those are the three pillars: clinical, electrocardiographic, and biomarkers. Again, three: electrical, biomarker, and clinical. They do an angio and it's normal, and so MINOCA includes the possibility of microvascular disease. And we said there are types of myocardial infarction, the most important of which are type 1, which is the plaque rupture or stenosis. There's the physical stenosis, and then the stenosis, it might be occurring over a long time, sure, but that's not MI yet. That's just a chronic stable ischemia. But then at some point, either the stenosis becomes critical, that it causes all the symptoms by itself, anatomically, mechanically speaking, or there is a plaque rupture or plaque erosion that causes an acute thrombosis, and then that causes myocardial infarction. That's what we most focus on or have been taught in medical schools. But then you come to the clinical world and you realize there's a type 2 MI, when you might again have a chronic stable ischemia due to a long-standing atherosclerotic plaque, but for whatever reason a stress state occurred or a vasospasm occurred, and then you get limitation of supply compared to demand. So it's a demand-supply mismatch. It's a functional MI, more or less, and it is precipitated usually by an underlying chronic defect, because you're supposed to be functionally capable. You should have the functional capacity of dealing with stress, but if you don't, then you can have type 2 myocardial infarction. Before I go on, you should know that there is type 3 MI, which is the one when you get acute sudden death due to a coronary disease, due to coronary ischemia. And then there's type 4 MI, and type 4 have A, subtype A, B, C, and they're all related to percutaneous intervention. So a stent is put, or a percutaneous intervention of some sort is done, and that leads to another MI usually. So you might have a chronic coronary, went to fix it, had an MI, or had an MI, went to fix it, and had another MI as a complication. And then finally, type 5 is CABG related. CABG is the open heart surgery, coronary artery bypass grafting surgery, and that is related to that. And they have their own clinical criteria, so you should be comfortable knowing that we have specific criteria that help us to define all of them. And you should also be comfortable knowing that no matter what the presentation, type 1, 2, well, 3 is going to be already dead, so you're not going to see that, 4 or 5. If they're presenting with the clinical pictures, your approach should be more or less the same. You should be very ready and ready to act very quickly. So, criteria for type 1 myocardial infarction: you want to have a documented rise of or fall of troponin values with at least one value above the 99th percentile upper reference limit. URL means upper reference limit, with at least one of the following. Symptoms of acute myocardial ischemia, new ischemic ECG changes, development of pathologic Q waves, imaging evidence of new loss of viable myocardium or new regional wall motion abnormality in pattern consistent with ischemic etiology. This is, again, pattern. And identification of a coronary thrombus by angiography, including intracoronary imaging or by autopsy. Okay, let's take this ECG. You should be able to very quickly realize that you have ST elevations here. Okay. Those we call the anterolateral leads, because V1, 2, 3, 4, 5, 6 are located like this, and they're called chest leads. And then 1, 2, 3 are basically 1, and then 2, and then 3. Those are the location of the leads. So each one of them is looking at the heart this way. Imagine this is where you're looking, right? Each one is looking at the heart that way, and that kind of localizes where you're looking at. The interesting thing about ECG, if a current is coming towards you, then the opposite side, if it's truly a myocardial injury, should have the opposite deflection, and that's called reciprocal changes. So you see here in one, if you have high anterolateral infarct here, then you'd have the inferior area and inferior posterior area should have some reciprocal changes. This is another pattern. Look here, you can very quickly see that, okay, here is depression and here is an elevation. All right, is this a reciprocal change? So the inferior part, and remember in the heart, because the heart is a pyramid shape, this is the triangle behind, this is the triangle in the back, and it's kind of also resting on the diaphragm, and so it kind of looks like looks this way. All right, it's in the back and it's slightly slanted upwards, and then that's the one in the back, that's the posterior inferior wall. Then there is the anterior wall, right, and then there is a lateral wall, and that kind of makes the three walls of the heart. And then there's kind of an upper area that is where the vessels come out from, and you want to localize the anterior, lateral, and posterior because it kind of covers or encompasses all of the muscle. So the upper part is not really muscle. It's just an easy way to like think of ECG. And so the inferior leads, the leads that look here, are also going to record with high level of accuracy the posterior wall because it is an inferior posterior wall. That's simple matter of pathology. So it's going to be this wall on the bottom. Okay. So this is the distribution of coronaries. You need to know that because of the way that the leads are 1, 2, 3. Okay, and then AVF, augmented lead, augmented vector, F and AVR, and AVR here and AVL there, right? So those are the limb leads. And so you know that 1 and AVL are lateral leads. You know that 2 and AVF and 3 are inferior leads. You know that AVR is the right-sided lead. And then the chest leads V1, 2, 3, 4, and 5. And here is the card you should kind of keep or save this image somewhere that you can approach quickly in your emergency rotations and your cardiology rotations, and keep looking at it, knowing that the lateral leads are those ones and they correspond to the left circumflex and the left anterior descending artery. Because if this is the heart, the left main gives you a left anterior descending and a left circumflex, okay? And then the right coronary goes that way and gives you the posterior descending as well. So the inferior leads are going to definitely, because inferior is posterior, okay? Inferior is posterior. Remember this very clearly, the way I explained to you where the base of the heart lies, where the base of that pyramid is, that's both inferior and posterior. It's just inferior posterior, okay? And so that corresponds to 2, 3 and AVF, and that's RCA or LCS because LCS loops around, so it also supplies part of the base, and that explains the concept of when they do an angiogram in the cath lab, they sometimes tell you there's a left system and a right system dominance, and that depends on whether the posterior part of the heart is mainly supplied by the left circumflex, so it's still the left system because it's still a branch of the left main vessel, or it is by the right coronary and its branches, and so that would be a right system dominance. Imagine that someone is a left system dominant, then they get a left main disease. There's a high chance that they might die. The septum in the ECG is appropriately referred to by lead 2, V1 and V2, okay? So that's also an additional caveat. All right. Let's take another example. Those are all ECGs from Medscape, by the way. We can see here that we have an ST depression. So here, indeed, you see lateral elevation in the V5 and the V6. Lead 3 looks okay in an inferior manner. AVF looks okay. AVL looks okay. But I really want to see posterior changes. What do I do in that case? Well, there is a simple trick. You see how we place our leads? Look at this image. This is how we place our leads, right? You can always give yourself an additional lead on the right side, right? You can put right-sided V6, V5, V4, and V3, and you can always do a posterior ECG. And so those will give you your reciprocal changes, okay? So feel free to do right and posterior ECGs. Okay, let's look at this ECG. This is also just to get in the habit of looking at ECGs. This is a 53-year-old patient who had experienced 3 hour of chest pain, 3 hour duration of chest pain. 12 lead electrocardiogram was performed and the results are shown. He was given sublingual nitro and developed severe symptomatic hypotension. This blood pressure normalized when they gave him volume resuscitation. That means they gave him fluids. And he felt like, okay, I am improved. So what that means is usually the RCA supplies the right heart. And if the right heart is not able to contract well, that means the blood is not capable of dealing with the volume coming into the heart. That's the preload. And so to kind of push fluids to the left heart, which should be functioning fine because the left coronary system is fine and the anterior part is fine, it's just the basal part of the heart is bad. The posterior, the inferior part of the heart is bad. And so you want to push the fluid to the left heart somehow through the lungs back to the heart to increase the blood output, that is the cardiac output. And so that would be preload dependent MI. Here, the ECG changes are also anterior. And whenever you see a patient in the emergency room and you have the capability of doing posterior and right-sided ECG, do it. And that is the reason and the objective of this scenario.